I'm going to talk about the management of aortic stenosis in intermediate risk patients in terms of transcatheter valve therapies or the choice of surgical valve therapies. There were two talks that were presented at ACC 2016, and one of the talks was called the Partner 2A trial. The Partner 2A trial is the largest randomized trial ever performed, where we actually had intermediate risk patients for surgical valve therapies for severe aortic stenosis. And half the patients received transcatheter valves, half the patients received surgical valves in a 1-to-1 randomization. What we found is that transcatheter valve therapies was non-inferior to surgical valve therapies. And so that was the overall TAVR pathway. It was about 20% of the patients had alternative access, and so 80% of patients had transfemoral aortic valve replacement. Of those 80%, the subgroup, when you look at those 80% transfemoral transcatheter valve patients compared to the surgical valve patients, they have a decreased mortality and disabling stroke at 2 years compared to surgery. So it appears that transfemoral valve therapies at a p-value of 0.05 was improved mortality or disabling stroke better than surgery. So I think that's really going to define that pathway. And what we did is we actually took the Partner 2A trial used the SAPIEN XT, which is a second-generation balloon expandable valve. The study that we call SAPIEN 3I, or SAPIEN 3 Intermediate, actually has the third-generation SAPIEN valve. And what we did is we did 1,000 patients, roughly, of the SAPIEN 3 valve in a registry format, and we compared them to the surgical patients of the 2A arm that I just described. Okay. So they were propensity scored. We were able to use all the patients. And in that study, what we showed is we had a composite endpoint, and then we have independent endpoints. So the composite endpoint were mortality, stroke, all stroke, not disabling, but all stroke, and also aortic regurgitation greater than or equal to moderate. In the overall combined endpoint, we saw that transcatheter valve therapies with the SAPIEN 3 was superior to surgery at 1 year. When we broke down when we broke down the components, we saw that mortality at 1 year, transcatheter valve in SAPIEN 3 was superior to surgery. When we look at stroke, all stroke, we saw that transcatheter valve therapy with the SAPIEN 3 was superior to surgery. We did see that surgery was superior to transcatheter therapies in the terms of aortic regurgitation greater than or equal to moderate. However, of note is that in this study we showed the lowest paravalvular leak rate of any valve platform ever so far. It was only 1.5% at 1 year. So yes, we do see surgery having less aortic regurgitation, but at 1 year we're looking at a 1.5% rate in transcatheter valve therapy. So we feel pretty good about that. There are a multitude of differences between them, but the three that I like to highlight is that, as we talked about the paravalvular leak rate, on the ventricular side of the SAPIEN 3 valve is a skirt, which allows decreasing paravalvular leak rate, and we've shown that now technically with a 1.5% 1 year rate. Number two, we have now, like I mentioned, we did 80% of the XT cases in Partner 2A were done transfemoral. We've now moved that up to close to 90%. With the SAPIEN 3 is because it's now a 14 French sheath instead of an 18 French sheath. And so we have some benefit with a sheath size, therefore more transfemorals, therefore better outcomes as we're seeing. The third component is that in the XT there were 3 valve sizes. With the SAPIEN 3 we have 4 valve sizes, 20, 23, 26, and 29. So you can really cover the entire gamut. Yeah, I think that especially in the transfemoral route. At Emory, we've been fortunate that we've been leading the charge towards minimalist TAVR. 70% of our patients don't go to the ICU after surgery. About 65% of them go home the next day. So they come in, they get their procedure while they're awake, and they go home the next day. So I think it's a big potential change. We have to continue to follow these valves. I think that the things of thrombus and other durability issues still need to be figured out. So I don't think that we're ready to move into a lower risk patients without a true randomized trial. And there are currently 2 randomized trials for low-risk patients in the U.S. currently. One of my other roles is I'm on the steering committee for the TVT database for the country, and what we currently have is just north of 400 sites doing this in the United States. There are a total of 1,200 sites doing cardiac surgery, so we're in almost a third of all programs in the United States. That's a lot. So over 400 sites is great. So it is now coming to most programs in the United States. There's a NCDR, an NCD, National Coverage Decision, benchmarks of how many aortic valves your hospital had to have done, or how many balloon valvuloplasties or PCIs that need to be done. So once you qualify for that, you can have the valve platform. Extreme risk patients are already being done with transcatheter valve therapies. High risk patients, after approval by FDA, are already being done mainly by transcatheter valve therapies, unless there's an exclusion criteria. Now, for the first time, we've shown in 3,000 patients at ACC 2016 between Partner 2A and the SAPIEN 3 intermediate risk trials that in some aspects with SAPIEN 3 we're showing that it's superior in some respects to surgical valve therapies. With SAPIEN XT we showed that it was not inferior. So it depends on what the FDA does, but if the FDA does approve this, which we think would be highly likely, then we would see a creeping of the use of transcatheter valve therapies into the medium risk patients, in addition to high risk and into the extreme risk patients. I think we go into low risk trials. I think we go into low risk patients, and we start to ask the question of which patient. Now we ask ourselves which patient should get a transcatheter valve. I think it's going to eventually come 10 years from now, which patient should get a surgical valve. And I think it's good for surgeons and cardiologists to work together, and I've always pushed that surgeons should be doing these in the cath lab just like cardiologists are, or in the hybrid room. So it needs to be an effort from both specialties, not one or the other.